Additionally, Dr. Oandasan is an academic family physician and full professor at the University of Toronto, where she is also the director of the Office of Interprofessional Education. She has designed a roadmap for the development of competent and caring healthcare professionals who believe in the practice of interprofessional patient centered care. Dr. Oandasan is a pioneer in healthcare research, having attracted over $55 million in grant funding and published over 100 articles. Her flourishing career makes her an exemplary role model for the healthcare professionals worldwide. Please, we are honored to have Dr. Ivy Oandasan with us today to share her insights and experience. So please join me in extending a warm welcome to Dr. Ivy as she takes the stage.
Thank you so much for the warm welcome, and Assalamu alaikum. My name is Ivy Oandasan, and I'm really privileged to come here and to speak to you all. I want to extend my thanks to Dr. Bara Al-Gayin for the invitation. What I'm hoping to do, let me see. My head is not, oh, this one's better?
Yes.
There we go here, and I think my head is only half in the picture. So you only see half of my eyes, so I'm going to stop for a second. There we go. Hello. It's a privilege to be here to talk to you. And my area of focus and interest is in family medicine education. And it is a specialty that I would say is still growing here in the kingdom. It is a young specialty here. I had many residents in my 30-year career. I had many residents that I had trained from Saudi that came to Toronto, where I practiced. And now I see them here as leaders, advancing the healthcare system as well as in family medicine in the kingdom. And it is, we're very proud to have had that influence upon them. I'm going to talk to you today about advancing primary care training across professions. And I'm going to talk about it as the fact that particularly in medicine, it's a team sport. We cannot do this alone as physicians. And the earlier we are able to recognize that, and the earlier we are able to begin to work and train with other healthcare providers, from the very beginning of your training into your practice, the better it will be by evidence for patient outcomes. And so my task today is to try to convince you that there is a need for team-based care, and particularly for you for Vision 2030, it's important for you to begin to recognize the value and how innovative and the opportunity that you can lead in the kingdom in looking at the ways you design your curriculum, how you train as students, and how you look to practice in the future for the best care of your patients. So first of all, let me see, who are students in the room? Hands up. Oh, very nice, very good. I have a test for you at the end. And are there any residents that are in the room? Teaching assistants, I hear that there are some teaching assistants in the room. Yes. And then are there any faculty in the room? Faculty, healthcare, family doctors, or other specialties? Welcome, thank you. So let's begin. And that's me. I want to say that the pandemic really played a huge role in what we do. And it provided many insights for me in my career as a family doctor. You see the picture beside me on the right, that's the team that I work with at the Toronto Western Family Health team. And I have 20 family physicians. We all work together, and we have a number of nurses and pharmacists and social workers. But what was interesting to me at the pandemic is all of a sudden, anyone who had the skill, who knew how to vaccinate, was called upon. We even had psychiatrists. My sister's a psychiatrist who was actually giving vaccinations. We had other nurses, anybody who had that skill came together. And it didn't matter who you were. If you had the skill, you were utilized because you were needed at the time. And I wondered, how is it that that happened, that we could maximize the skill set of healthcare professionals who had similar skill sets when they were needed? And how come we can't do that now? Because there are many healthcare professionals who have similar scopes of practice as us as physicians. And yet we as physicians are the bottleneck. We're the bottleneck and everybody else has to wait in order for us to see it. What if we were not the bottleneck? What if we were at the top of the chain to actually see those that actually required our expertise and knowledge? And that we utilize other healthcare professionals who have similar scopes, but not to the depth. And that they come to the physicians, and I'm going to talk family physicians here, as consultants to them. Wow, that's different, huh? A family physician as a consultant? What is that? Family physicians consult others. We do not consult, we are not the consultants, right? But what if we were? To other primary care providers, what would that look like? And what would we be able to do in the healthcare system if we were to maximize the healthcare providers that had similar skill sets but could come to us for consultation when it's beyond their scope? What would that look like? How many more patients would we be able to see? So my area of interest became teamwork in healthcare, because I wondered to myself, I'm working with this pharmacist and the social worker in my practice. I don't even know what they do. They see patients. They see patients. What do they do? How come I never knew what these pharmacists do? How come I didn't know what a social worker does? How come I didn't know that the social worker could do some counseling? And so my patient didn't have to wait 4 weeks to see me because they needed to actually have some counseling services, but they could have gone to see the social worker in my practice. Why? Because the way that we train as health professions is siloed, right? Medicine here, nursing here, pharmacy here, social work here. At no time do you ever interact at the undergraduate level, yes? And even when you go into the hospital, even when you go into the clinic, do you ever interact with the other healthcare provider students? Rarely. And so in 2005, the government of Canada had issued a call for proposals, because at that point in time, this is 2005, okay, there was a recognition that we would be in a crisis, a healthcare crisis of shortage of healthcare providers, 2005. And so they wanted to understand the evidence for teamwork in healthcare to improve the efficiencies and the care outcomes. And so I bid for that. I was a very young researcher at the time, just 2 years out of my master's from my residency training. And I thought, well, let me do it. And I got it. And what I realized is that it is a science. It is not magic that you come together and you learn and you actually know what other healthcare providers do. It is not magic that you know how to communicate effectively and negotiate. You have to actually practice it. You have to practice that, and you have to reduce your assumptions and your biases for the other healthcare professionals, because you don't know. And so what I started was on the left-hand side is a theoretical framework that was created that talks about on the green that you must have education in your training across all health professions of how you need to come together at different times in your training to work with other healthcare professionals, to learn with other healthcare professionals, to understand what they know and what you know and how you actually can work together. And once you graduate from the green health education system and move into the red practice system, the practice system must support the practice of team-based care. Now, in the hospitals, that actually happens, right? You have rounds oftentimes in the hospitals, you'll have the patient safety elements, talks, etc. In primary care, where does that happen? Doesn't happen. Because there is no structure or system in the primary care centers to actually allow that to happen. And so one of the faults that we have in the healthcare system that was built after the World War II was a young population that got sick, broke a leg, went into the hospital, got their appendix out, and came home. Now, and all the monies were put into the hospitals. Now we have an aging population and a complex chronic diseases. And we don't necessarily have a system to support like the hospital structure does when our patients are in the community. And our family physicians struggle because our family physicians are there on their own when in fact they need a team. They need a team of a pharmacist and a dietitian and a social worker and a psychologist who can help when there is multi-morbidity in your patient population. Why is it that we actually end up in primary care on our own? It's because the way of the system, the way that it was structured. But what's exciting for me, and I'll share with you a few slides, is what I'm seeing post-pandemic, what I'm seeing here in the kingdom is a real interest in relooking and creating a true primary care system, one that will support the family physicians and other healthcare providers, who will reduce the amount of utilization that would be in the emergency departments and hospitals when the specialists are just overrun right now, which requires a new generation of family physicians. And so I'm here to convince you that this is the field that I'd love for you to actually come and join. So with Dr. Bara and myself, because we love what we do. But it is applicable to my hope for you that you'll see the applicability to Hugh in the kingdom. So I was told by my father, you will be a physician. I had no other option, right? I was a baby and that was it. You're going to be a doctor, that's it. I didn't know what a doctor was, but I had no other choice, right? And I didn't know what kind of doctor, because all I had was a pediatrician, so I didn't know. But it was after my first year in medical school in the summer that I spent a summer with a rural family physician. And it was in the northern part of Manitoba. And Dr. Robinson, I lived with her and I worked with her. And I delivered my first baby. I was a first year medical student. I was able to deliver and the baby's last name was Ivy. Ivy delivered the Ivy baby. Right? And I was able to be in the OR with that family physician, who was actually the one who was assisting the surgeon and the obstetricians when they were doing C-sections. And I was able to fly to a remote community where there were Indigenous people, and I was able to provide care for them because they couldn't actually come down to the city. And I worked in the emergency department and saw a motor vehicle accident and had to manage that. And I had to help her when there was the first heart attack that I had ever seen. And I worked in a long-term care facility. You don't have many of them here, where for the elderly, that they would actually be staying. And I was able to work there. So out of the clinic, we would go there after hours and we would go in there, and then we would go back into the hospital and do the rounds there, because she also brought her patients into the hospital as well. And what I saw was how a family physician saw the breadth from babies to death, from acute care in the hospital to lumps and bumps to take out the cysts, And I thought, wow, that's so incredible that I can do that. And I fell in love with family medicine at that time. And luckily for me, during my training at the University of Manitoba, I had many, many role models of comprehensive family physicians that did that kind of work, that loved that kind of work, and were supported to do that kind of work. And now, in my role as the Director of Education at the College of Family Physicians of Canada, and I've helped to implement and evaluate the new curriculum reform that we had. And sad to say, after 10 years of implementing, what we thought was going to be a solution to help support the increased numbers of family physicians, the increased diversity of family physicians, what we found were that our graduates were not wanting to practice comprehensive family medicine. Many of them didn't even want to actually do family medicine. They just wanted it as a fast track. And so many of them are not practicing what we actually train them to do. And what a waste that is. And the reason for that is not necessarily just the education, but it's also because the practice system was making it more lucrative for them to practice in the emergency medicine only, or practice in the hospital only. And that working in the community was not lucrative. So why? Why then go into family medicine? And so the hope that I have in the work that I do right now is to help people understand that if we want a very strong primary care system that actually shows evidence that improves patient outcomes, population health outcomes, then you need to reform not only the education, but you need to reform the practice in the system. And only when you do those two things will you be successful. The promise of family medicine, we know that countries that have very strong primary care systems that actually have access to primary care providers and family physicians who are able to do the breadth of comprehensive care, your populations are better. They live longer. They actually are able to access the care that they require. And that there is lower mortality recognized by evidence across countries that have strong primary care systems. And in 1978, the World Health Organization had the declaration, it's called the Alma Ata. And the Alma Ata had said that it is a right for every person in the world to have access to healthcare. You should not be able to receive healthcare if you don't have funding. You should be able, if you are sick, that you should actually have access. And there was a declaration in the World Health Organization for countries to support the advancement of healthcare for all. And embedded with that was the foundation of primary healthcare. And so advocates like Dr. Bara, and yes, and others who are working towards moving this area forward have been working at this for years. We did not get there at 2020, because at 2020, by the year 2000, that's what the hope was, that we would achieve the health for all. So we didn't get there. So what happened was there was another declaration in 2018, a renewed commitment for universal health coverage and the principles of person-centered primary health care to enable health for all. And when you look at that Astana Declaration, and you look at the healthcare sector transformation program that the Kingdom is actually advancing, you will see many similarities in what is coming forward. And in there is the foundation of primary care. And so this is what I found. So you do a little bit of research before you come in, and so you're reading about it. And I was impressed with what the vision is for 2030. Again, the details are always, the devil is in the details, they say. But the vision is strong. And the vision says, if you look on the left, facilitate access to healthcare services, making sure quality and efficiency of health services, promoting prevention of health risks, enhancing traffic safety. That's a big one because I have not been driven, but I've been driven here, and that's scary. But improving the life of the Saudi people. And the way that they're looking at that is through integrated healthcare. The connection between primary care and tertiary care, and to be able to actually within the primary care sector, which includes home care, which includes long-term care and primary care facilities, is to establish and ensure that it is well supported, well structured, well funded. And it is here where the opportunity lies, particularly in the training sectors. Because if we believe that in the training, that family physicians and other healthcare professionals need to be working within this particular sector, they need to be trained in that area now. And we need to think about, how do you do that? And the opportunity are in these primary healthcare clinics, I think, in the future, which are going to require many, many family physicians who will do the kind of scope of work that what I was actually articulating earlier. So the role of the Saudi family physician working in these kind of clinics, I think that that's around the circle. They're responsible for that around the circle. That means that you need to finish your training that starts within medical school and then foundationally within your training to actually ensure that you have the competencies and the capabilities to do all of that, which includes chronic care, last phase palliative or care, planned care, preventative care, safe births, urgent care. So when you look at the current situation, there is a shortage of qualified family physicians in all healthcare sectors in Saudi Arabia as a result of the lack of a strategic plan for the training of family physicians. And so that's what we're trying to fix. And I don't know why all of my slides are in there, but in the back, it showed a little bit about how you design your training programs to actually do that. What we share in common with you is that you have a shortage. We actually also have a shortage. And that shortage is actually getting worse, which is one of the reasons why, and I'm proud to say that the governments in Canada are also looking for ways in which we actually increase our numbers, but also increase the utilization and bringing in other international medical graduates to come into the country, because we have an access issue as well. And so the challenge for governments is, do you just continue to produce more and more? You'll never have enough. With the amount of people that are retiring, that are leaving, that are reducing their scope of practice, that are doing administrative work, regardless, if you continue to try to produce more and more of the physicians, it's not going to be enough. And so there's many of us who say we have to work differently. We have to look at a new way of how we actually maximize utilization of the healthcare providers that we have and utilize them and utilize our skills to the utmost. And so the social accountability mandate that was put out by the World Health Organization as well says that it is an obligation of medical schools to direct their education, research, and service activities towards addressing the priority health concerns of the community, region, and our nation. They have a mandate to serve. If there's a crisis in primary care without access, is that not an obligation of a medical school to actually try to focus upon and fix? And with that, requires experiences within the primary healthcare sector. So I've been focused upon thinking about, in my job at the College of Family Physicians of Canada, in helping with shaping the design of training for family physicians. Are we producing the right number, the right caliber, and distribution of primary care providers to serve population needs? And through the evaluation and the data that we've been actually collecting, we realize that it's not enough. And we need to do more, which is one of the reasons why we're in another phase of reform at this point in time. So how then do you design training for the outcomes desired? Well, you need to think about who are you going to enter into the medical school? And will they actually be interested? No, I'm not saying that everyone, but they do say about 50% of the graduates, if they are working to comprehensive scope, should be in family medicine. So can you identify who are the ones that would be interested in going to medical school in the outset in order to define that they will get there at the end? And then when you're in training, do you allow them within the medical school to experience working in the family practice context? Do you get them to see when they leave and go to a residency training program, the different ways in which a family physician practices? And do you help them in the design of the curriculum to focus on the identity and the pride of being a family physician? When many say, oh, you're too smart to be a family doctor. Why are you? It's a waste of time for you to be a family doctor. Why are you a family doctor? Right? So you design your training to influence the family medicine identity and values and the pride. You ensure you provide exposure to the comprehensive scope of work of a family doctor from the very beginning of your medical school training, because it is the foundation of the medical system. You ensure that this is, people just don't believe there's a competence for, what is a family doctor competence? What is that? You just know a little bit about everything. We know the red flags. We may not know exactly what is the issue with the eyelash specifically, but we do know when there's something that really needs to be seen about that eyelash and that it is a problem. And we know that because we've seen so many before. And our depth of knowledge is such that we know where the red flags are and what is urgent and what is not. What needs to be seen today or what can wait for a week for a referral. That's what we know. We know what is in from the ambiguous. We know what are the challenges that can come from that. And we know how things impact the person holistically. I know when not to treat somebody because it's their anxiety. Otherwise, you just give them a pill. But I know that's because of the abuse that they had when they were younger. Because I have learned to integrate the biopsychosocial spiritual elements for the patient. And I know that because I was taught that. And that is a competency of family doctors. We do not see just the heart. We do not see just the abdomen. We see the whole. And in order to do that, it is a competency that we can assess and we can identify. It's not for everyone. And so what I often say to people is, you know, we get this problem where people are coming into our training programs and we say, oh, we need everyone, we have to fill all our family medicine spots. I don't want all our family medicine spots to be filled. I really do not. Because if people do not want to practice the way that we believe family medicine should be practiced, I don't know, is it wushu? What was the wushu? No? Okay, sorry. Anyway, just never mind. Don't come into family medicine because you're wasting a spot. What is the outcome then? What is the outcome that you want for training? You want our new graduates who will practice comprehensive family medicine where they are needed. And that includes some of your rural areas, that includes many of the areas that people cannot have access to care, because we in family medicine are the ones that take care of the ones that often cannot have access to care. So in 2010, I helped to lead the development of this CCC, competency-based curriculum. So it's really fancy at the time, you know what, you define what your competencies are, you design this whole curriculum, and you know, our training program is 2 years. So we put our residents through there and we hope that they will be competent by the time that they leave. And we evaluated it. And oh, I don't know how, we evaluated through the very strange slide. But on the left-hand side are all the elements related to family medicine, competency-based education. And we were able to put all of those elements into place. Across 17 family medicine residency programs, over 750 clinical teaching sites across, because we were all working together towards moving that forward. And what we had to do is really articulate, what do we mean by comprehensive family medicine? So that we could actually train our residents to actually finish. And so we needed to ensure that our curriculum was giving them exposure to all people, ages, life stages, and presentations, that they knew how to deal with clinical domains, both acute and chronic, all stages from preventative to palliative care, and that family physicians work in different settings. We work in primary care clinics. We work and we train in emergency medicine. Dr. Bara, does a lot in emergency medicine. Home and long-term care, hospital care, and maternal and newborn care. And so our expected outcomes then are that you are able to have all of these elements when you come out. So there was a study that looked at primary healthcare reform in Saudi Arabia, and it was the one that said that you actually need a primary healthcare system that needs some reform. And in there, that it needs to be based on team-based comprehensive primary care, which is a way of saying that multiple healthcare workers are going to be working around that circle. And that collectively, you will be able to provide access and quality of care. But you can't do it unless you actually practice it. And you can't do it unless you actually have seen it. So you need to actually be able to, and I'm going to say it's your generation that will be able to do this. It's your generation that will be able to do that. You will drive the changes that are required. If you believe that every Saudi person should have access to healthcare, we need something like this. And so when you think about all of the comprehensive services that are expected, because we need to define them, is it right, and this is what I usually say in Canada, is it right that I can go to a family doctor and the family doctor says, I don't see women. I don't want to do anything related to dermatology. How is it that you can choose? What is the expected element of what everyone should actually expect to receive if they have access to a primary care team? We should be able to define what those services are. And we should be able to say, it's not just the family physician that will do that, but the family physician team with all of their healthcare providers will deliver on those services. It should not be that you can say, I'm not going to do that. I'm going to refer. Because you were trained. You were trained for the full scope. So what might it look like? In a team with nurses, pharmacists, dietitians, they're booked with patients who know them because they know me as a family physician and they're part of the team and we know our patient population. And they would see them. If it's a cold, I don't need to see them for a cold. They could see somebody else who actually has those skill sets as well. But I expect that my healthcare professional who sees that that person may have a fever and some other spots that look a little bit worrisome, that they would come and consult me at the time. And my time is used effectively. That family physicians are consulted when needed, when it's out of their scope. That there are team meetings on complex patients, particularly because we have older and older patients that are there, that we come together as a physician and a pharmacist coming together for a medication review. That when we have complex patients with 2 or more health issues, they're known by multiple healthcare providers and we come together and dialogue about them. And because we have an electronic medical record, that information is coming to me and I know, I always have a sense as a physician, I always have a sense. that potentially well women care, well baby care is provided by nurses, nurse practitioners in collaboration with family physicians. And that over decades of care, remember, I'm 3 decades in my practice right now, that over decades of care, you get to know your patients because you develop a relationship with them and the team develops a relationship with them. What this also allows is that as a family physician, I could be involved in more complex planning of the healthcare that's required for that patient population. I can identify with the research skills that I have, I can identify what are some of the things that we can do differently while people are doing some of the other work in the primary care context. I could be working in places where there may not be a geriatrician, and so you need more focused care provided so I can take on that care as a family physician because I can add value and learn more to provide the care for the geriatric population. That's the beauty of family medicine. So the fluidity within a team allows you to be able to do more and allows your patients not to wait for days and hours upon end. So if healthcare providers are expected to work together, it only makes sense that their education and training should prepare them for this type of working arrangement. I'm sorry for my slides. And what we found in one study is that when they were looking at the review of the primary healthcare clinics as part of the primary healthcare reform in Saudi Arabia, they recognized that much of the staff lack the training in chronic disease management, lack the understanding of communication and interpersonal skills. Why? Because they were never designed to treat them. So when I hire our nurses in Canada, they have never set foot in a primary care clinic. How are they expected to know exactly what to do? It's magic. Which is one of the reasons why we're saying that every healthcare provider should actually have availability and experience in the primary care context. If we're going to build this kind of system, then you need to train them and train them in teams. So primary care training for all healthcare providers to be competent and comprehensive in the team-based approach. And you train them in team-based primary healthcare clinics with very top of scope family doctors. And with that, we hope that you will get the outcomes that you're hoping for in Vision 2030. And that is the future design for training to meet population need. There was a time in Canada prior to 1954 when the federal government created the Royal College of Physicians and Surgeons, because they felt that it was important for them to have a good standard of education for the specialists. The GPs at the time said, well, how come we can't be part of that college? I said, well, what does a family doctor know? And so our original ancestors came together and said, we want our own college of family physicians of Canada. We want to demonstrate that we have competence in assessments, and we want to demonstrate the height of what we do. And so we created that. What we're saying now is that not only do we need to look at it from a family medicine perspective, but nursing and pharmacy and all the other healthcare providers need to have a similar kind of training. And again, the new role of the family physician will be as a consultant to them. In order for this all to happen, you need primary care reform. You need to actually have the infrastructure that will support that team. It will require a different funding model. And you are moving towards a different funding model that actually can support this kind of approach. And that you need to be able to ensure that the graduates that are going to be coming and working in those kind of contexts are ready to do so and know how to do so. So that gets me to a project that I just received, so $45.3 million from the federal government in Canada, to look at enhancing the capacity of interprofessional comprehensive primary care. Practitioners who work in teams to improve how they deliver care in the primary care sector. Big grant in order to try and help it, and it was training. And so what we're doing is we have 20 healthcare providers coming together and helping to understand what are the competencies that you require, specific to working within primary care, and where can you have the opportunities for your learners to actually be able to go and practice and learn how to do that. And so we're bringing together all of these, and they're all creating their own training programs right now. But not only do they need to do that, they need to come together to learn in the primary care sector how to work collectively together. And so there are competencies that need to be taught about how you learn about the roles of other healthcare professionals, how you learn the communication practices, how you learn the values and ethics and the importance of working collaboratively together. And you understand the roles and responsibilities of those that you're working with, so you can maximize each other's skill set. And so that needs to be put into the design of the curriculum, which we put into the grant. We also, within the grant, have identified we've funded projects to become better at teams. And so we've given them consultations, and we're giving them coaches, and we're giving them training to actually help them to be able to work in this way, because you cannot just bring people together and think that they can do this. It requires training. And so we hope by the end of the year, we hope at the bottom that we'll have 20 healthcare professional training programs that will now influence accreditation standards for primary care that is an expectation across all health professions. And that we will have resources for teams, and we will have ways in which we can move this forward from a team perspective, from the educational side. In Saudi Arabia, it is said that the Saudi Arabian healthcare system needs comprehensive reform with a focus on primary healthcare. It's part of Vision 2030. How do you do that? Well, I would say that you start also with looking at your outcomes of your training and what your graduates are going to need to do by 2030, by 2040. What does it look like? And you begin to train them, because you will be the ones that will be training the other ones coming forward. You are the ones that are going to need to do this and build this within your own country. And it must be matched at the same time with practice reform. And that's what's actually we're hearing, but I'm not seeing a lot of the training elements of it right now. So the call is for the trainees, the training environment to be in line with the practice environment so that we're ready together. So my take-home messages: education can influence population health outcomes. The way you design your training programs can actually help influence those that will become family physicians, those who will choose to work in this particular sector, and you design for expected outcomes. You know that there's changes coming. What is it going to be expected? What are the healthcare providers going to be expected to do? How do you align training with other healthcare providers so you're not just training physicians, you may be training others as well with you in interprofessional education, which is a mandate. In Canada and the United States and the UK, it is mandated that you have to have interprofessional education, learning about, from, and with other health professional students from year one of medical school training. Inform and get data to increase your ongoing improvement. And as I said, the future will be linking education reform with practice reform initiatives. With that, I look forward to advancing team-based family medicine together. We hope that there may be some opportunities for collaboration in future. And I look forward to coming back and seeing some more of the incredible transformations that are happening here in the kingdom, and looking to see what you will do to actually influence as well. Shukran. Thank you very much. Of course.
Thank you, Dr. Ivy, for your distinguished and thought-provoking keynote address. Now I would like to invite the audience to fruitfully and engaging Q&A discussion panel with Dr. Ivy. Please feel free to ask any questions to share your thoughts on the topic I discussed today. Okay.
Hey, hello, doctor.
Hello.
We have been anticipating your visit for the entire month now, and we realize that you are a leader of the family medicine competency-based care model. And my question is it like a one-size-fits-all model? And would you kindly give us a few examples of the work which has been done in Canada and how it can be implemented in different countries, like here in Saudi Arabia?
Sure. So when the whole process in my slide was actually confusing there. The way the competency-based medical education is different from what we currently have is in the past, we said, oh, you have 4 years of training and you just throw things in there, right? What we say at this point, so you'd say, okay, you know that as a physician, you need to have 4 weeks in obstetrics, 4 weeks in surgery, 4 weeks in so and so, right? It's like, if you throw somebody in the pool, do you think that they're going to learn how to swim in 4 weeks? Well, I just throw you in the pool for 4 weeks. Yeah, you should learn, right? So the difference in competency-based medical education is you define specifically what is the outcome you want, the knowledge, skills, attitudes, behaviors, and then you work back to design it to ensure that they get those knowledge, skills, attitudes, and behaviors. In addition, you recognize that it is important for the learner to gather these skill sets in a sequential way, right? What I often see in my practice is we get our first-year family medicine residents and they are seeing the hardest of hard patients, right? Yeah, because nobody wants to see the hardest of hard patients. Let the resident see the patient, right? What we do in competency-based medical education is be able to understand that there are early elements that you need to learn and consolidate and then move to the next. And so there's milestones that you learn. And to do that, particularly in family medicine, what you require is that you have ongoing elements of assessment. And I think you're doing that here already, right? So the ongoing assessments is with a coach that actually can look at what you're doing and say, you're able to do this, this, and this, but you haven't had experience in this, this, and this. We need to make sure that you're having that. Or, oh, you're looking like you're having some difficulty in this component here. You need more experience of that. And so we tailor the learning for that. The other is that in competency-based medical education, it's not just about the exam at the end, because the exam only measures your knowledge. In competence-based medical education, you look for workplace assessment. So what's important is the ability for you to actually demonstrate time and time again that in the clinical environment, you actually are demonstrating your competencies. And that is documented. So those are the elements that are there. The last thing I'm going to say to you, which I didn't put in this presentation, is what we learned is competence is not enough. So what we heard in competency-based medical education is that, oh, you just have to make sure that they pass the exam, competent. What we realized is our residents passed their exams, but they weren't practicing to full scope. Why? Because they actually didn't feel confident. They didn't have enough exposure. And so we are moving to no longer just competency-based education. We're moving to capability, outcome-based capability, which we actually are saying that you actually need a consolidation year to actually be able to consolidate your skills. And you need to be able to, you may be able to deliver a baby in a tertiary care hospital, but we want to put you in a rural hospital and see what you can do there. And so the adaptability of a family physician is what we're expecting. And so you need to actually demonstrate that in various different contexts. So the move that we're having is, and you will start to hear this, family medicine by 2027 is moving to 3 years in Canada. The third year is going to be a consolidation year, where we will be bringing our learners and our residents into particularly areas where they do not have access to care. And so that our residents will be able to provide that care. in those particular sectors as well, and that there'll be less supervision. We'll let you swim a little bit, maybe drown, not completely, but enough that you actually have to learn to rely on your own skill sets. So that's where we're moving. So beyond competency-based education is kind of the new stuff that's happening. Yes, please.
Thank you, Dr. Ali, for presentation. Actually, here is absolutely about it that they are going around, they talk and they are training people about team-based care. It's in English, they call it team-based care. In Arabic, they call it totally different thing. They call it طبيب لكل أسرة. It means one family physician for each family. Actually, in English, they are calling team-based care, but in reality, they are not doing it. I think one of the biggest problems that we are facing in reality that physicians themselves, family physicians, they are resisting the team-based care idea, and they are obviously trying to fail it. I don't know exactly why. I wish that if you have experience about this to guide us, how we can overcome this resistance as a family physician. Even myself, sometimes I feel it's very difficult to work as a team because working alone, it is easier, faster, and I know you won't reach that far away as you are working in a team, but still it's very difficult, especially in hectic, busy clinic. It's very difficult to change completely practice from a solo participation or solo clinic one-to-one to team-based. This is number one. Number two, I think one of the problems of that why our residents they are not having the confidence to do things because we lack the tools in our primary healthcare centers. Yeah, for example, even if for example, I'm skillful in the procedure, but in our primary healthcare centers, we don't have the instruments, we don't have the facility to help us to teach, to learn or to work or to apply what we are learning. Okay. So this is another problem. I think number one, we need to improve our skill and to continue improving and practicing it. We have to have better infrastructure. Okay. So till now we have unfortunately poor infrastructure. I don't know why till now they are resisting the idea that family physicians they can do things. Once they don't believe that family physicians they can do things, they will not supply them with the material and the tools that they need. And I'm wondering, in rural areas in Canada, does they have all the facilities? Does they have, for example, like I'll tell you something. If I have a pregnant lady who's having labor in the primary health center, I'll not be able to do anything. I don't have the clip. I don't have many things needed basically to help her to deliver. So in the rural area, maybe they are having the facility, they are having the tools. Here we don't have it, and this is what is killing our passion, what's killing our interest to learn more, to practice more. When the residents they are having their training in the hospital, they have all the facilities. They learn things. But when reality, when they come to the clinic in the primary health care, they find nothing to do what they learn to practice. So how can we do this?
So what I find is that when I talk to government, they don't understand what the scope of what a family physician can do. They have their own ideas of what we do. Oh, you just write a prescription and you send them around. Right? They don't know what we can do to the maximum if we have the infrastructure, which is one of the reasons why, as I said, it's both education and practice reform. We have to be able to share what our discipline can do. And the problem is that we've been training people, but that they go out and they don't have, as you said, the infrastructure. So it's a waste, right? So there has to be conversations to say, if the vision is this for what family physicians can do, then you need to provide them this from the practice infrastructure. And you need to give the learning and the learning infrastructure for that as well. Because if this is the ALMA, if this is the ASCANA, and if this is what governments are all saying that you need a strong primary healthcare system, they don't know what that is. They really don't. And we need to be the ones to actually try to tell them that. The other that you said is, why are we as family doctors resisting? Because one, we're generalists. We're supposed to do it all. That is the belief system. The belief system is that we are the ones that have to take care of it all. We don't know how to share. And so when you have your family medicine residents that are there, you don't want them to go and learn from the dietitian, because you're saying, oh, you can't learn from the dietitian. Yeah, you can learn from the dietitian to incorporate into your practice. And we feel threatened. The family doctors feel threatened from the nurses, who the message is from, in Canada at least, I can do everything that you can. As a nurse practitioner, I can do everything that you can as a family physician. No, you cannot. And this is why, because we have not actually articulated what is our scope that we can provide. If you do that, wow, what an amazing thing that we could actually highlight to share. Because we haven't done that in family medicine. We haven't defined our competencies clearly. We haven't defined the scope or shared the stories of what it looks like when you have a really good family doctor and what difference that it makes.
You know what's my belief is, we shouldn't be training, you know, in the residency training for family medicine. We shouldn't have at all trained our residents to go to the hospital. At all. I tell you why. Because simply they will not be ready, you know, like keen to improve the infrastructure if the residents they are having their training in the hospital. Okay? If the essence of that, if the primary health care is not well equipped and not, it doesn't have all the facilities, that means the residents will not train. So first they have to fix the primary health care, then they have to do residency program. What they are doing now, okay, just they are sending our residents to the hospital to watch everything there, to know what is there, then to go to the primary health care doing nothing. Okay, they are losing trust by themselves. They are feeling that they are lower or inferior than the superior and specialized people in the hospital, that they have everything. Okay, unfortunately, the people that in the leadership, they don't care about improving the primary health care because they have things in the hospital. They have everything in the hospital. For example, let's say the CEO of Cluster X, okay, he has everything in the hospital. He will never need to go to the primary health care. He improve the primary health care. This is what's happening, unfortunately. I think we need to put the leaders from the people that they are working in the primary health care, not the vice versa. Very specialized tertiary care, they put them in the CEO for managing primary health care. Wallahi, they don't know even how the primary health care belongs.
So some of the things that are happening in Canada, they're trying to move, as you said, most of the training is in the primary healthcare clinics, bringing the specialists to us so that they actually have to learn and provide the consultations in the family medicine clinic. And so surgeons are doing some of the lumps and bumps, and then they bring our residents in there. Why are we always going out to the hospital? The other is, when you look at the kind of lectures that happen in the medical school, if you're teaching about diabetes, how come it's the endocrinologists? Family physicians can actually talk about the generalist approach to diabetes. And so again, it starts from the vision of, if you want this, you need to demonstrate and role model it from the very beginning to medical students. Family physicians need to be demonstrating their skill set. And unfortunately, there are many that are out there that are not necessarily doing the scope of what we hope. And that actually creates a challenge for us. My hope is for, again, the new generation, that you will change that. And we've been able to do that. But it is you that can actually make the change in the future.
Thank you so much. I'm really happy to attend with you again. We have never met in Toronto, but we met here. So I have comments and questions. My comments may be extended to what my colleague comments here. about family medicine identity. I think this is a very challenging issue. And I'm really astonished that you bring up that even our colleagues in Canada, that they have this problem that of having identifying themselves as family physician, as generalists. So I think we are sharing some challenge here. A lot of our colleagues, they just finished the board of family medicine and they got some fellowship in diabetes, geriatrics, whatever, and they label themselves and they identify themselves as geriatrician, neurologist, and so on. That means at the end of the day, they are not find themselves doing what's the basic family medicine board is equipped them to do. So I think part of it is the environment, the general environment and culture that we are facing. We have a very high competitive environment as a physician.
Yeah.
And this might also extend to what you said about we assume that we know everything. Let me give you, I don't want to take time, but let me give you one example from my practice. I practiced being a consultant as a family medicine, but it was not an instruction way. It was my own, process. I was in an area that's considered to be a small city. And when I went there, some of my colleagues, they said, we will never go and work in that small primary care. We don't have anything like what Victoria said to do. I decided, no, I will go. I will do the best as I can, and I will try my best with the patient and with my colleagues there. Their GPs, that means they just finished their medical school and they came to work as a GP. And I sat with them and I told them, okay, I'm here, I'm a university staff, I'm a qualified person, but I'm one of you. And I will be there for you if any case during the week as you feel that there's some challenge in it. Please keep it to me in my clinic day. And believe me, the challenge here is not only the physician, the patients also they have challenge because they don't have this belief that this primary care setting gonna solve some of their problems.
Yeah.
Please just refer me to the specialist. It took me a long time to convince colleagues, to convince patients that we can do something. Okay, I'm not assuming that I succeed, but at least I spent most of my time there to change this belief in my students, my colleagues, and my patients. So I think it's a journey. It's not a destination. So we need to accept this challenges that it will never happen. That you will find everything ready for you. You have to fight, but you have to fight with a belief in yourself and in your specialty, and you value what you are doing, even if it's just talking.
Yes.
And this is what I'm talking to my students. Even if you just build up a relationship like what you said, this patient will stay with me for at least 10 years. So this is a success by itself. If he keep coming to me, I feel that he is not reaching the point that said, okay, I have to change this person. I have to go to another one. So this is a success by itself. My question. You are proposing a very nice reform about team-based primary care. And your essence, as I understand, is the interprofessional work. So my question is, don't you think that if you do it on the level of graduates, you are missing a piece of the core business in the undergraduate interprofessional? Thank you.
Thank you. Yeah, for the comments that you were saying, it is a multi-pronged component. I will tell you that what has happened in Canada is we're now seeing, we had a rise in interest in family medicine, and then it is now dropping again, right? We had the high of about 40% first choice family medicine. We are now down to 33, and it's going down. And part of that is it's a multi-pronged approach to actually increasing the value of family medicine. And so that I understand there's somebody from the society here, but the work of the College of Family Physicians of Canada, not only just the accreditation, but we do the communications and the advocacy and going to government, but it requires a significant amount of planning. What I was proposing is if you can link it to some of the reforms that are happening in Saudi that are they don't even talk about family medicine, right? But we can share that this is what we can do. This is our contribution. Right? In terms of the interprofessional education, I actually say that it must happen at the undergrad. So what we do, what I designed in University of Toronto was 1,400 students from all of the faculties came together, and they would come together on a 3 or 4 times a year. And we created a competency-based curriculum in interprofessional education, so that they actually would just in the first year, they all came into a room, say, hey, this is the value of team-based care. You need to understand that because one day you may be working with somebody in this room. And then we do some work on communication. We just do some work on conflict resolution. And then they have to actually do interprofessional placements in clinics as an undergrad. Where we have failed is in the postgrad. In the postgrad, this doesn't happen, which is one of the problems, even though the CanMed's roles is collaborator role, and we don't even know how to teach it, is because we actually haven't put it into place. Because again, many of our clinics in Canada they're solo practitioners. They're not team-based, but we know that the governments are moving more and more to team-based care. And so with that, we need to switch our training programs for that as well. So thank you for your question.
It was very nice to be with you here. I think I'm the only one who comes from nursing background, but I'm very delighted to be with you. And just commenting any question, right? I'm very interested when it comes to competence-based education, because I come from education background and the interprofessional education. That's good to do it at undergraduate level and to teach different people. The example you say from different faculties they study in the university. Our particular, can you give us an example if we want to, because my education and training is supposed to do such thing, interprofessional education in the clinical area, in the practice. What sorts of things or examples you can give if we wanted to, do it in training?
So if you know what the competencies are, includes understanding the roles and responsibilities of other healthcare providers, looking at the ways that people are communicating effectively and being able to actually negotiate in terms of deciding a care plan. So, and also the value of patient-centered care, that is the competencies that you expect. Then there's a foundational time at the undergrad that allows you to actually understand the knowledge of that, right? As you move up into your undergraduate years and you're in the clinical environment, then you actually are given more responsibilities that you can do. So an example would be what we did was we said, okay, internal medicine. Who are the learners in internal medicine in the hospital right now? Oh, there's a nurse, there's a medical student, there's a pharmacy student. We just bring them together. Let's bring them together once a week where they can talk about their patients' care and because they're sharing patients, but they never even talk together. And the approach is that you're not going there to teach them about the medical issue. You are there as facilitators to help them understand their roles and understand the competencies of, are you communicating? How come the nursing student isn't speaking? It's because she's scared of the family, the physician who is there, right? But the inability to speak will cause a patient safety issue in the future if you do not intervene. And you identify that as communication is essential, that you have to feel empowered to actually speak if you feel that there's something wrong. And so the opportunities are to bring them together once a week. We usually do it for an afternoon, so that they can actually see a patient together, talk about it, and then we facilitate that, that they actually will go and attend a rounds. And they have to see, again, we talk about the competencies. So reflect upon, how is the team interacting? What are the communication elements over there? What could they improve upon? And then we ask them also to shadow and have conversations with the other healthcare professionals that are in there. Because a nurse or a social worker in the obstetrics ward will be different than a nurse or social worker that is in a family medicine context. But the interprofessional elements of those competencies remain the same, but they differ in the context. So that's why it's important for them to actually have those opportunities no matter where they're going, and to consolidate them over time. So we have a whole curriculum component. I'm happy to share that with you. It's all on the website. You can have all of it if you like. But there's a good base of knowledge for that that's been developed.
And I think it's increased also the teamwork, collaboration, respect to each profession.
Yes.
So we understand each other.
Completely. And it reduces burnout. It reduces burnout, improves psychological safety, and makes you enjoy your work better. Yeah.
We'll get to the microphone.
Hi, Victor. It was very interesting, and I enjoyed actually listening to your beautiful presentation. I think it's very important. I'm going to take the optimistic part of the approach. I think family medicine is going to be one of the most important specialty in Saudi Arabia soon. I had a very good relationship with colleagues from the Royal College of Family Medicine in Canada. Dr. Francine Lemire, she was my friend. We worked together. I was the president of Embo. I worked with her and Richard Robert, and we always talk and discuss this big issue of the pessimism of family medicine practice in some countries. And I think our region is one of that lucky zone who has a very unfortunate practice of family medicine, as we know. So most of our physicians, when they practice a lot of high standard specialty. And when they go to, like Dr. Rola mentioned, when they go to the practice, they find that they are actually not in the right resource environment. But I think what we want is really keep developing the training, keep the cooperation between our international programs. I think we have in Saudi Arabia excellent family medicine program. We have the Arab Fold also, which is doing very well. And also we have in some universities like Dammam University, they have their own fellowship program. But most of our programs is really compatible with the international standards. Now, what I would like to tell my friends here that maybe you will be surprised that we have a problem in the data that we have in Saudi Arabia. 100,000 physicians, less than 4,000 of them are family physicians. When the ideal standard says that we should have 50% of the total physicians in any country should be family doctors. So there is a problem in the equation, which is coming now soon to be readjusted. 50% should be in primary care now. We have less than 15% in primary care and about 75% in hospitals. Dr. Ola mentioned that the resources in hospitals should really be available and accessible for the primary care physicians to at least address the primary care practice, which you don't need in this case to refer the patients to hospitals when the procedure is within your capability. So I think this is not going to be a problem. I think everybody should be ready for the change. By 2030 in Saudi Arabia, I expect that this ratio will increase. Many doctors, as what happened in Canada and the States, most of the hospitals moved from hospitals to primary care and start to move toward family medicine. So this will come to Saudi Arabia. Now, one of the major challenge for the family physicians in Saudi Arabia that they are salaried and they are employees. They are not actually contracted as in Canada or Australia and other areas where a physician is contracted to be responsible for example, 1,500 people.
Yeah.
And unless this change, I don't see much improvement at this time. But I think it's coming that the term of or the policy for contracts will change, like what happened in most of the countries, including Canada.
Yeah, yeah.
Canada contract changed only in the 90s. The idea started in 80s, but in 90s they started to have a direct contract. By 2000, I think they started to have obligation that everybody should have a family physician. And I think this will happen, is coming also to Saudi Arabia. So every physician then will own his practice, will be empowered. He will choose his team. He will work with his team. He will understand the meaning of the team and how important is the team for the practice. And I think this is the ultimate goal, and it will happen. The only thing that we should learn from each other, we have our own experience actually in our region, completely different than the American, the Canadian, and so on. In rural health here, we have also our own beautiful way of dealing. Actually, primary care is more successful in rural areas in Saudi Arabia than in urban areas because of the continuity of care of physicians for that. So I think the situation is really promising. Cooperation with your college is very important, other colleges, and I encourage that we really have this cooperation. And I would like to thank you for this beautiful presentation.
Thank you so much.
On behalf of Alfaisal University, we would like to express our sincere gratitude to Dr. Ivy for taking the time to share her expertise and insights with us today. I would like also to take this opportunity to thank Dr. Bara al-Ghalalini, who once again have shined as a leader in global engagement initiatives and as a pioneer in advancing education and interprofessional care. At this time, I would like to invite Dr. Bara to the stage to honor Dr. Ivy for her outstanding achievements with the Alfaisal University Appreciation Coin. As we come to the end of today's event, I would like to extend my sincere gratitude again to Dr. Ivy and Dr. Bara, our esteemed attendees and our amazing volunteers and the amazing organizing team also. Your presence and engagement have made this event a great success. We would like to invite you all to continue the conversation and joy during the networking reception. It's in the atrium outside the theater. If you exit to the left, you will find it to the left. Thank you so much for today.